Welcome back, CardioNerds. This is Gurleen Kaur, and we're so excited to be back with another episode in our Narratives in Cardiology series designed to promote diversity and inclusion in cardiology. I'm here with Dr. Diane Masket, CardioNerds Academy intern and internal medicine PGY1 at the University of Chicago Northshore. Today, we're so lucky to virtually be visiting the ACC Indiana chapter as we talk with our guest, Dr. Minnow Walsh. And with that, I'll turn it over to you, Diane.
Thank you so much, Gurleen. It is truly such an honor to welcome Dr. Walsh to represent the Indiana ACC chapter for the Narratives in Cardiology series. Dr. Walsh is the Medical Director of Heart Failure and Cardiovascular Research at Ascension St. Vincent Heart Center. Dr. Walsh has been active in the ACC both locally and nationally, in various roles from President of the State Chapter to chairing multiple committees, and serving as the ACC National President in 2017 to 2018. She's also the lead author of the recent ACC Statement on Career Flexibility in Cardiology. Dr. Walsh, it's an honor to have you here with us today. It was a delight to learn from you on CardioNerds episode 283, where we talked about a challenging case in cardio-obstetrics and heart failure. And today we are excited to learn about your personal and professional journey, as well as delve into your recent statement on career flexibility. Thank you so much. Welcome back to CardioNerds.
Very great to be here again to talk about another topic that's really important, I think, to the college, to all of us in our profession, and also to me personally.
Great, thank you. So I think we're just going to dive in, if you're okay with that, and just start asking you some questions. So the first one is the 2022 ACC Health Policy Statement was monumental in analyzing and defining specific parts of a cardiologist's work-life balance. I listened to your interview with Dr. Sharon Hayes regarding the statement, and I would really love to start our discussion today by asking you the very same question you asked her. Why did you personally think it was important for the ACC to come out with a comprehensive policy statement on career flexibility in cardiology?
A great question, because I posed it to her. So let me just say, I think it's important, if we're going to talk about this statement, for everyone who's listening to understand that why the ACC, why the college puts out a policy statement. So that's kind of an important underpinning to all this. So the ACC, when there's something, a topic or an issue that will involve our statement or our influence regarding other institutions, the government, other stakeholders, when we say we're going to put together a policy statement, it's really that we're going to put a sort of a stake in the sand and say, this is how the college views this particular topic and views that this is really important. So policy statements, if you Google or go on JACC, because they're all published in JACC. If you go on JACC.org, if you look it up, you can see health policy statements on a lot of different topics. Many of them are disease-based rather than profession-based. But so that's kind of the background on what a policy statement is. This statement grew out of the Diversity and Equity and Inclusion Task Force of the college, which is now a standing committee. And we realized that in order to make our field, the field of cardiovascular medicine, more diverse, more inclusive, that we really needed to look at issues around the workforce, not just things about who are we, who's coming in, who of you younger people who are training, like who are we bringing into the workforce? Well, one of the barriers we knew was the lack of flexibility in our field. So it's been well documented by literature. There are a lot of papers, I can tell you which ones they are, that show that our field has a very poor perception from people who are coming in, medical students, internal medicine residents, maybe even college students, saying, that's really not, cardiology is really not a field that I want to think about because it isn't flexible. And it was kind of based on that data that the Diversity, Equity, and Inclusion Committee said we really need to focus on flexible careers. But even though we knew, we thought we'd get a lot of blowback because we all know there hasn't been a lot of flexibility. So we thought we would get from a lot of very senior people that they would say, what's the need for this? We never needed this when we were young. So that's the background. And I was all in when I was asked to chair. I mean, I volunteered. I said, this is the one I would like to chair because I think this is important. It's something I've been writing about during my entire career. I wrote about flexibility in training in 1990 in a newsletter talking about how we really need to increase flexibility in our field.
Thank you so much, Dr. Walsh, for sharing that. And it's really helpful to hear kind of how the ACC thinks about health policy statements and the background of the Equity, Inclusion, and Diversity Task Force. And your reflections on the motivation behind the statement of how to make the field more diverse and inclusive is really similar to the motivation behind our Narratives in Cardiology series at CardioNerds, where we've been having faculty at different levels and stages share their personal and professional journeys of how they've crafted their career in cardiology, both highlighting like the vast spectrum of possibilities and career options that the field offers. And kind of shifting more into some of the details of this health policy statement, first of all, I think for anyone who's listening who has not yet read the document, I think this conversation should definitely inspire you to do so. But secondly, I think to give some idea of what the document encompasses, it begins with 18 principles that the ACC endorses for career flexibility. And the first one states that all cardiologists should have access to flexibility in hours and work commitments according to personal needs, preferences, and expertise, while being mindful of the patient, program, team, and institutional needs. And both me and Diane are beginning a new transition of training, with Diane starting internal medicine residency and me starting cardiology fellowship. And I think this statement really sounds ideal, but I think we've heard different opinions and different kind of perspectives from seasoned physicians who have shared the realities of their career. So Dr. Walsh, I'd like to ask you, when you started working on this document, what was your vision of how the requests that are being put forth by this statement, how are they going to be implemented in reality of various institutions across the United States?
We had no idea how this was going to be received, but we did hope that this policy statement would be shared widely with a lot of different stakeholders, including institutional leaders, deans, chairs of medicine, chiefs of cardiology, program directors of cardiovascular fellowships, program directors of other fellowships, internal medicine leaders. But we certainly didn't know if that would happen. And we knew for sure that there was going to be pushback. And I think what's inherent in that first principle is that the described flexibility needs to be available. But probably one of the most important things, and we go into this in great detail in the policy statement, is, you can't expect total flexibility in your career and to have the same compensation package as you might have if you had, so a full FTE, when we call 1.0 FTE, that's somebody who's working full-time, full call, full everything, taking, doing rounding in the hospital, everything. So if you want some flexibility at any time in your career, whether it's early, mid, late, we know that although the principle exists, you also have to understand that we're all a team, we're all working together. And if one person needs some flexibility, that generally translates into fewer hours in some way or another, whether it's a change in the call, a change in the number of hours worked per week, and number of hours worked per day, how many echoes you read, etc. So inherent in that is the need to also understand, as the person seeking flexibility, that there has to be a change in compensation.
Great, thank you. Thank you for your insight into that. I remember as I was reading the statement that certainly struck me. And I mean, in terms of the volume and the compensation certainly is going to be related. So I think that makes a lot of sense. And thank you for telling us a little bit about the background of that. Particularly when I was reviewing the document, I was very impressed by the attention paid to cardiologists at all stages of their career, and particularly the advanced career cardiologists who ultimately kind of wanted to decelerate, but they didn't want to completely retire. And I'm just curious, when you were interviewing cardiologists to write this health policy statement, what was really the major desire of advanced stage cardiologists, and kind of what types of extra clinical interests do advanced career physicians express? Because I imagine it's very different from early stage physicians.
Maybe not as different as you think, because the need and the desire for flexibility is really kind of similar on both ends. It's just what maybe you're going to do with your time is a little bit different. But probably really importantly, let's pause and talk about who the authors of the statement are. I didn't really, and we didn't really interview people. I had selected people, all of whom I knew quite well, specifically for their various roles and times in their career. One example, we have people from administration in multiple different ways. We have Mike Parmasek, who's one of the authors, is the chair of medicine at the University of Pennsylvania, and he's a cardiologist. He's been a chief of cardiology and now chair of medicine at Penn. We have John Warner, who at the time was CEO at UT Southwestern, now at the Ohio State University. And we had Joe Cashone, who at the time we started the document was vice president at Ascension, where I work. And now he's the he's the CEO at Jefferson in Philadelphia. These are all cardiologists. These are all people who run systems. And what we knew was we needed the administrators to tell us, this is all pie in the sky. You can't do this without, a compensation package. So we needed their thoughts and deep review of this whole paper to say, what do you think? And to a person, they were, really engaged and really interested, and also gave us guidance on what the system needs from the standpoint of these cardiologists who are generally now almost all employees. So we had the administrators. We also had early career cardiologists. I won't name everybody. And we had very senior cardiologists participating. We also had a fellow in training. Jim Origi participated, and he is now the CEO of the ACGME International. He's a cardiologist, and he knows everything there is to know about training, ABIM rules, ACGME rules, etc. Joanne Foody was a writer. She is in industry now. She's a cardiologist. Sharon Hayes was on, as it was already mentioned, Claire Duvernoy. So we had women, early career, late career, mid-career, administrators, everybody that we could think of who would have a stake in this. So with regard to what senior career people want, it's sort of the deceleration pathway that hasn't really been talked a lot about either in academic medicine writ large or in cardiology in general. There are many practices in cardiology where you are all in or all out. Particular practices, I mean, like if you want to stop call, you're out. You can't decelerate and say, I just want to stop night call, maybe weekend coverage, but I still want to do I'm ready to go for another 5 years, whatever it is, and I'll do everything else, rounding in the hospital, doing my clinics, reading my echoes, doing whatever. There are some practices, many practices, who have said in the past that, nope, you can't do that. You're all in or all out. We wanted to address that, and we did. And it's my hope that some of these practices have changed. I can't tell you how many individuals I've coached to, not young people, when I say coach, give this document to your senior leaders and show them what's going on in cardiology, because we all get sort of insular and in our own practice or institution, we're like, well, I don't know how it is out. Well, out there, it's very different. And we gave examples of programs where this was possible. So later career cardiologists want more time to do other things. It might be other academic interests they have, writing, or maybe industry, or maybe just spending more time with their family. might be a little different than early career, but those are kind of the 2 times of the career that we see that people really want the most flexibility.
Thanks for sharing that, Dr. Walsh. The wide spectrum of authors that were included in this statement and stakeholders from different career stages and also people from administration, I think that's remarkable and speaks to what the statement is putting forward. And that's recommendations at all career stages and also recommendations that different institutions and stakeholders will try to incorporate and be applicable to people, whether that's early career, mid-career, or late career. And you touched on this a little bit earlier that one of the motivations behind this was to enrich diversity because there might be people younger in training that might not consider the field because of the traditional lack of flexibility. And I imagine that you and your colleagues might not have had this type of flexibility in your career and wanted to make some changes in the generations to come to make the field more inclusive. So I'm curious to know more about if this discussion on flexibility had occurred earlier in your personal career. How might you have structured your career differently at the various stages? And what did you wish you would have asked for earlier on that maybe you didn't feel comfortable requesting at that time of your career?
Yeah, I'd like to answer that in a really broad way and say that a lot of people in my generation or about my age began to ask for change early on, and it was not always met with any sort of warm reception, shall we say. But an example I'll give rather than my particular, because I have a very, I think, amazing group practice that I work with. It's huge. I'm going to tell a little bit about it because we've moved pretty rapidly toward really a lot of flexibility. And I want to tell about that because I think our group can teach a lot of people. But I'll give an example of Dr. Janet Wright, who's a senior cardiologist and was in private practice she's past trustee of the college and now working with Million Hearts and an amazing leader. She decided in her 5-person practice back in Chico, California, back in the 90s, that there were only 5 of them. She was the only woman, and she decided that she wanted to take an afternoon off per week. And she told her partners this, and she said, I'll have my pager on. I'll answer the phone. I'll do whatever. However, I'm not going to be scheduled in the office or reading echoes or whatever it is. Or in the cath lab, but she was an interventional cardiologist then. And this was met with shock. And what are you talking about? Nobody's ever done this. Well, she said, well, that's what I'm going to do. And she knew she wouldn't be billing during that time. So she would take less in her take home and compensation. And it was I want to remember that it was within a year that every one of the cardiologists was taking an afternoon off, different afternoon off per week. So asking for change began slowly. I will say that I always say that women were the canary in the coal mine. Women were the ones who went forward and said, I want some flexibility, be it, I want a no-call position. I want maybe one day or a half day per week, whatever it might be that's different. Women were the ones who came forward. A lot of times early on, it had to do with childbearing years, etc. But the reason I say that women were the canary in the coal mine, this is discussed all the time now. And people in your generation, in your training programs, everybody wants it now. Everyone's like talking freely, openly. And the first time I ever heard a man ask this question, I was at an unnamed university. I could say what it is, but giving like grand rounds, being the visiting professor, and I had time to meet with the fellows, and a first-year cardiology fellow, so a little bit farther in the year than you are, Gurleen, but not much. We were having this robust discussion of the future and what they were thinking about for their jobs. And this male cardiology fellow said, how do you think I would be received if I tried to negotiate for a less than full-time job when I get finished? And I couldn't believe it. I was like, what? Oh my God, this is fabulous. People are moving along. This is wonderful. And I said, well, I'm not sure. It depends on where you'd go, but you might want to use it as a litmus test for where you want to work. because if you're met with, no, that's not possible, maybe that's not where you really want to work. So I'd say early on, our generation was a lot of women asking this or doing this kind of change in schedule, and now I'm happy to see that it's more universal for people like you all who are training and who are early career people.
Thank you so much, Dr. Walsh. I think something that's really important is in a career is really to reach back and help the generations following in your footsteps. So first off, I just want to say thank you for doing that for all of us who are training right now. While late stage cardiologists will definitely, benefit from the deceleration you're kind of discussing, I do think that up and coming trainees will ultimately, hopefully, be benefiting for all of their career. So just thank you so much for really paving the way for that. And so something else that I found interesting in the statement, and I'm curious kind of how you are hoping to monitor the, hold on, sorry, let me redo that. I'm going to start from the question. It was indicative of the ACC's openness to change that they were willing to put out a statement like this. And we're, hoping it creates a path forward for other medical bodies to do the same, kind of like what you were discussing earlier. How will you ultimately know if this health policy statement helped drive the needle in the direction you were hoping? And is there a way you all are planning to kind of study this and look at its impact?
Yeah, that's a great question. I wish I had a more targeted answer as to, we put metrics out in the field and we're trying to figure out the impact. It's impossible to determine whether this policy statement in our field was the sole thing that changed anything. I do know that I just know sort of anecdotes, people saying, I have used this and brought it to my leadership and requested that we have a change in the way we do things. Generally, these have been places that are more practice-based, not as much university. I remember early on seeing a download on whatever website I was on. I can't remember how I saw this, but it was like ResearchGate or something. And I saw that Daryl Moyers, who's the CEO of ACP, which is all of internal medicine, CEO of that organization, had downloaded it. And I thought, there you go. Now we got the internists interested too. Every field's different. OBGYN, for example, 85% of OBGYNs are now women, are in the training portion are women. It's heavily, it's a surgical field, lots of call, lots of burden, and lots of flexibility built in. There's a lot of laborist positions and a lot really creative ways to think about job sharing and everything. So it's hard to see if cardiology changes just because and in the college wrote this document, rather than looking outside and seeing how other fields are changing. Not every field is changing. I doubt ortho's changed very much recently. I don't know. I haven't looked into that, but so I don't think we can kind of rest on our laurels and say this document moved the needle exactly. But I know I know just from people talking, and I've done a lot of grand rounds on it and gone to chapter meetings to talk about it. So I know it has become valuable and used by cardiologists, and that's really what we wanted.
Yeah, it's definitely hard to study the exact effects of a policy statement, but I think an important aspect, like you mentioned, is the anecdotal influence of the statement, the conversations it leads to, and just knowing that a large academic society such as the ACC is the one that spearled this initiative and is kind of bringing it to people around the US who read Jack, who are avid kind of followers of ACC. I think that's definitely very meaningful, kind of where it's coming from the ACC itself. And just to pivot a little bit and talk about some of the other principles that the health policy statement focuses on. So the 9th principle reads that cardiologists choosing flexible hours and work commitments should not be penalized unnecessarily in work assignments, promotion, leadership, opportunities, compensation, and so on. And since many cardiologists might identify missed career advancement as one of the reasons that they're unwilling to ask for a more balanced work life, I think this is an important aspect to talk about in this statement. And how do you envision, Dr. Walsh, how program directors and leadership might be implementing this and how the ACC can track that aspect in terms of influence?
Well, as you know, the ACC is really the home, I think, for fellows in training, and so we're very as an organization, we're sort of the home also for the program directors in cardiology. But those program directors in cardiology report to program directors in internal medicine. There's a whole hierarchy in training. So if we think about training, more than just cardiology, we have to think about what has the ACGME and the ABIM said recently, like, well, what do we think about flexibility? And happily, there is more flexibility for those of you who need or wish to take time off for whether it's family planning or taking care of a family member, things like that. The time that has to be made up in training can be modified by your program director such that, for example, you don't necessarily have to spend 3 additional months after your intended graduation date in order to complete all your responsibilities. One of the most important things that college is really behind and pushing is that competency-based evaluation should be what is used in fellowship rather than this sort of cookie cutter approach of you have to do this many months of echo and this much of cath and et cetera, et cetera. And even maybe going forward in COCATs, which I don't know if everyone's familiar with COCATs, but that's the recommendation that the ACC makes every few years around what should be required for training of cardiovascular disease fellowships. Maybe not everyone needs to take 3 months of cath. Maybe if you know for sure you don't want to do cath, you do a month, that's enough. You know how the procedure's done, et cetera. So flexibility in changing from volume to competency, so that if you, Gurleen, know how to read echoes and are doing great at a given time, and you've read, and you're a fast reader, a fast learner, and you're done, you don't have to do 3 more months of echo. The chair of your echo department can say, she's ready to take the echo boards already, and so she can go do something else, do preventive cardiology. So the college is behind that and supportive of that. It is the ACGME and the ABIM that make those rules, though. So I think flexibility, moving from sort of volume to competency, is one push, and the other is for the ability for trainees to take time away as they need to for whatever issues they need to. And it shouldn't always have to be illness or family planning. It could be the most amazing. This isn't a training person, but one of my colleagues here in town at a different institution took a 6-month sabbatical to go to New Zealand during a time when his wife had some funding there to do research. And it was like, well, are you going to fire me or just give me the time off? And the institution said, yeah, we want you to come back. But it doesn't always have to be family planning or sickness. And I think we have to get out of that mindset. That was a long answer to a more specific question you had. So if I didn't answer it, let me know.
No, that was really helpful, and it's definitely interesting to hear about the flexibility in training and competency-based education. And we actually touched on this topic in one of our earlier narratives episode as well, where we talked with Dr. James Arrighi, who I know you mentioned was also involved with this policy statement. So it's really eye-opening to hear your perspective on that aspect as well. And you mentioned earlier how in your time, women were the ones asking about flexibility. And I think still women are underrepresented in the field, with most recent numbers showing that 23.7% of cardiology trainees are women and only 14% of working cardiologists are women. So it'd be great to hear your thoughts about ways that you feel cardiology as a field can help close these gender disparities. And how do you think this career flexibility document plays a role in making cardiology an attractive career choice for women?
Update, as of July, it's 26% fellows are women. So incrementally every year we're getting a little bit better. So that's always good. I think there are several answers to that. One is the field has not been welcoming to women because of a lack of flexibility. But the other thing is that the culture has not always been welcoming, and a lot's been written about that, especially the culture in the cath lab, for example, where there are actually some surveys of general cardiology fellows who didn't go into intervention versus those who did. A lot of work has been done in this area, and it's pretty clear that and surveys of internal medicine residents who say I don't see it as a welcoming field. So in order to make the field more welcoming, we have to change what is on offer. And I think that we have to continue to use flexibility as one of the things that we allow for. I think you probably, just in your previous training, that, there are a lot of family medicine, internal medicine residents who have pregnancies. It's pretty routine. It's handled really quite well for people who have a majority women, like family medicine has majority women now. Internal medicine has about 43, 45-ish% every year. It's kind of a routine thing, but in cardiology fellowship, it's like some, in some places, it remains like some big deal, like how much call and how much cath lab time and all this running around stuff. That has to end. It has to be as routine as in other fellowships or in other fellowships. So I think changing that environment, but I think we had a really shocking paper that came out here in the last couple of weeks about how many women interventional cardiologists leave the field early. So this lack of this sort of culture, and it's kind of an overlap, flexibility and culture kind of working together to say, why are we not retaining? Now we have to turn our attention. Why aren't we retaining women? We're retaining them in cardiology, but they're not staying in the lab. That's a culture problem that we hadn't. That was news. That data that came out a couple of weeks ago was shocking. So we have a lot of work to do, and both of you are early in your training programs, and you must feel I'd like to hear what you think. I mean, Gurleen, how does it feel to you? I'm going to do this for at least 3 years. How do I feel? Do I feel like I can live my life during this whole time? Or am I going to be like, do I feel like I'm in jail? Yeah. I mean, that's how, fellowship is daunting, and internal medicine residency is too, but I think culture is how we feel every day. And I think the more we increase flexibility, the more the culture is going to shift.
And, on that note, I do really think that in general, outside of internal medicine, outside of just cardiology, that the discussion around culture is being had a lot more. Even at, I just finished medical school. Even at the medical school level, we're discussing it, and attendings are very open about it. And there's no more kind of just blindly going into a field and not thinking about how it's going to impact the life that you would like to lead and where your priorities are. So I think it's something that medicine and all specialties are starting to think about more, which I think hopefully will continue. And on that note, we talked about earlier that deceleration often happens later in one's career, but in the policy statement, you did discuss a little bit about women specifically needing to decelerate early in their career to often accommodate the childbearing or child-rearing responsibilities. And this is kind of coupled with the idea that mid-career women can pick up responsibility and increase their productivity as other personal responsibilities decrease. Do you find that this is starting to also include men, since there is definitely an increased emphasis on men taking full parental leave and increasing responsibilities at home, and really an emphasis on starting to kind of share that load?
I do feel that men who are early career, maybe even fellows, are more interested in the same career flexibility that women have often talked about, especially when there was a need for. So one of the natural sort of breaks in a woman's training or career is the time of maybe pregnancy and parenthood, and then not only the time away during the leave that is needed, but then maybe coming back later as, do I want to finish my fellowship, on time, or do I want to do my fellowship? Can I talk to my program director about doing this half-time so that I finish a year later? Just, I'm making this up out of my head, but some sort of issue like that where you could negotiate that you could have some time that where you'd meet all your responsibilities eventually, but it would be over a less truncated time period. So I think we see that. And then, so yes, I see this in men now, that fellow that I told you about asking if he'd be able to get a job as a less than 1.0 FTE. The thing I wanted to say about my practice is we're an Ascension Medical Group in Indiana, is a very large cardiology practice, about 85 cardiologists statewide now. And we now have 6 men who are working 0.8 rather than 1.0. These are, I'm not talking about the career people who are on my end of the career, where a lot of people have stopped night call and have gone back to a 0.8 or a 0.6. That's very common in my group, and it's allowed. We have rules, we have the whole deal, we have it all written out so that this is, yep, you step back this much, this is how much comp you lose. But all of a sudden, in the last few years, we've had men come forward and say, I want this. We've had women before go to 0.8 at a time of early career. And I will tell a funny story that one of our leaders, when we were having a discussion about this, when a couple men came forward a few years ago, somebody said, well, I guess if we're going to let the women do it, we have to let the men. I laughed at him. I said, unless you want the lawyers here, I think yes, yeah. But what amazes me is the request there. It's happened there. It's this year we've had 2 more people. So, and we're saying, honestly, this is true. We're saying this, we think this will be our opening contract for everybody coming forward. Like, who wouldn't want it? How much money do you want? There's all these, discussions of how we would do it. But so yes, there are more men interested now than ever. And I think they learn from the women probably, but I think the pressures, not the pressures, but the need and the want to be a co-parent can drive this. Although I always say this, one of our men who did this 3 years ago is not a parent. And so everybody, you got your life to live, you want to do other stuff. So that can be a driving force too.
Dr. Walsh, it's been a really insightful discussion with you, and your point earlier about culture of a field and culture of a training environment, I think is really important. And as Diane mentioned, I think we're talking about culture throughout career stages now. And personally, as someone interested in med ed, I think we talk about it a lot in terms of the educational environment as well, like setting a culture where learning can thrive and learners feel open to ask questions and make mistakes to learn and really nurture that growth mindset. And I've definitely heard medical students or other trainees mention that they thought cardiology was really intimidating. So I think it's really up to all of us at each of these stages to make it an open field, whether that's as a fellow making it open for residents and medical students, or even at Diane, your stage as a resident when you rotate through cardiology, having that open culture of learning within cardiology to make it attractive to medical students who are kind of looking up to you as a role model, as the next kind of person, right, kind of proximal to their stage of training. So I think all of this has really helped me kind of reflect on all of those aspects as well in our discussion today. And during our narratives episodes, we also really like to learn about our speakers and our guests on the show. So Dr. Walsh, we know that you've been such a trailblazer leader in cardiovascular medicine and a role model to all cardiologists, and particularly women in cardiology. So as you look back at your own personal and professional journey over the years, we'd love to hear a little bit about your reflections on your path to leadership. What were some obstacles you faced and how did you overcome those?
Well, we all have obstacles. I don't know that I've had any more than anybody else. I am at my sort of age and tenure, I was there were not very many women in our field, but it was also that's not something that made me not go into our field, but it was something that you had to deal with sort of on an everyday basis. I was the first woman who was pregnant in our fellowship, and that was the director, not the cardiology director, but the interventional radiologist who led the cath lab at the time, because believe it or not, cardiologists weren't in charge. It was radiology. He tried to get me, kicked out of the cath lab. And I said, no, I said, no, I have registered with radiation safety. I have a dosimeter. And I said, you can't kick me out. I've registered with radiation safety. And so those sorts of things seem antiquated to me now, because your program director wouldn't let that happen. At least I hope they wouldn't. But so I think probably the biggest thing, and if I would tell any young person listening to this, here's one thing you have to learn how to live with in balancing your life and your career and what you want to do and how you're going to go forward, what challenges you should take on. You have to learn to live with ambivalence. You can't do everything. You can't do everything all at one time. And so when my children were young, I didn't travel as much. I gave some opportunities up then. I was ambivalent then. When I accelerated towards some of the leadership roles I did and scientific work I did, I traveled more. I felt ambivalent that I wasn't at home. And one of the skills, if you can develop it, is probably to learn how to live with ambivalence. The joy of being later career, the ambivalence falls away because you don't have as many things tugging at you. So that sort of writ large, that's the opposite. And then just probably becoming, there hadn't been a president of the college who was a woman for 12 years since Pam Douglas had been president. So that was a sort of a daunting decision it was something I wanted to do, but it was also something I did because I thought we needed to have another woman president. And as of today, if you saw the announcement, we have our 7th woman president, Vice President Roxana Moran, who will become Madam President in a year. So that's exciting.
Thank you so much for going a little bit into that ambivalence. That sounds like something we all need to get.
Ambivalence every day.
That's okay. We have to learn to live with it and embrace it and not let it, inhibit us from reaching for our goals, but then also being okay with stepping back when it's the right time in our lives to step back. So thank you so much. As someone, I'm sure Gurleen feels the same way, to hear that from someone who's such a seasoned cardiologist. That's really, really great to hear. Dr. Walsh, we really cannot thank you enough for taking your time to be here today. The Narrative in Cardiology series, as Gurleen mentioned earlier, is one that CardioNerds is particularly proud of, since it's rooted in the goal to promote diversity, equity, and inclusion in cardiology. And we really always like to end with a special question. And if you've ever listened to any of our episodes, you know this. And that question is, what makes your heart flutter about the future of cardiology as a field?
Well, I'll say that actually, the flutter happened today when I got the news that Roxana got it. It's now routine to have a woman president. The second time a woman's following a woman. This is like, I feel like, okay, well, that's rolling in the right direction. That makes my heart flutter. I want to see more, certainly want to nurture our other underrepresented in cardiology folks. But that kind of thing really makes you feel like it was worth it. Kind of all the work that has preceded when you kind of see the visible representation of diversity becoming routine. I think that's a heart flutter for me.
Thank you so much, Dr. Walsh, for taking out time to talk with us tonight. It's been so great to learn more about the ACC Health Policy Statement, to hear about the backstory of its inception and the different topics, and also your own personal and professional journey. You've just been such an inspirational advocate for career flexibility and women in cardiology. We're so honored to have you on CardioNerds and have our listeners learn from all your wisdom. And I think I'm taking a lot away from this discussion, including the importance of how to learn to live with ambivalence. So thank you so much.
My pleasure. It was really great. Thanks so much for having me. And hopefully in 10 years, we won't even need to talk about women in cardiology anymore because it'll be just routine.
Yeah, that sounds wonderful.